Savai Mansingh Medical College, Jaipur. Today, we have a teaching class on pathogenesis of UTI and recurrent urinary tract infection. So the topic is pathogenesis of UTI and recurrent UTI. This will be presented by our resident, Dr. Rajeev Kumar, and would be moderated by our faculty, Dr. Ajayraj Hada. So I would request now Dr. Rajeev Kumar to kindly share his presentation.
Thank you.
Go ahead. Dr. Sayam, please help.
So is the screen visible?
No, it's not visible. So till we share the screen. So let me say that urinary tract infection is a very common problem, right, throughout the globe. It affects around 150 million people in the world.
So screen is visible?
Screen is, yes, now it is visible. Make it full screen. So as I was saying, it affects 150 million people every year. And make it full screen, please. It affects more women than men. And the incidence is around 12% of all women and 3% of all men are affected by UTI. So I request Dr. Rajeev Kumar to go ahead with the presentation, please. Go ahead.
Thank you, sir. Good morning, everyone. Today I am presenting a seminar on pathogenesis of UTI and recurrent UTI. UTI is an inflammatory response of the urothelium to the bacterial invasion, usually associated with bacteria and pyuria. As the name suggests, bacteria is the presence of bacteria, and pyuria is the presence of WBC in the urine. Bacteria without pyuria is generally indicative of colonization of bacteria without overt infection of the urinary tract. Pyuria without bacteria is seen in recent UTI treated with antibiotics, steroid therapy, malignancy, and GUT. Recurrent UTI is an infection that occurs after documented successful resolution of an antecedent infection. It is of two types. Reinfection is a new event associated with the reintroduction of bacteria into the urinary tract, whereas the bacterial persistence refers as recurrent UTI caused by the same bacteria re-emerging from a focus within the urinary tract, like infectious stone or prostate. Relapse is a frequently interchangeable term. Complicated UTI is associated with factors like functional or anatomical abnormality of urinary tract, male gender, pregnancy, elderly patient, immunosuppression, and hospital-acquired infection, and the symptom for more than 7 days as at presentation. And in the pathogenesis, UTI is a result of interaction between uropathogen and host. For the successful infection of urinary tract, there are three determinant factors. One is the virulence factor of bacteria. Second is inoculum size and the inadequacy of host defense mechanism. Routes of infection, the ascending route is the most common route of entry of bacteria in the urinary tract from bowel and skin reservoir via ascent through the urethra into the bladder. Adherence of pathogen to urothelial mucosa plays an important role, and as the edema associated with cystitis may cause significant changes in the UV junction to permit reflux. Homogeneous route is the uncommon route, and occasionally it's seen as a secondary infection in patients with Staph aureus bacteremia originating from oral site or with Candida species. Lymphatic route is furthermore an uncommon route. Direct spread of bacteria from the adjacent organ may occur in case of severe bowel infection and retroperitoneal abscesses. This picture depicts the ascending infection caused by E. coli, Proteus, and Enterococci, in which the bacteria enters through the lower urinary tract and after the with the vesico-urinary junction derangement, it ascends into the ureter, and after VUR leads to the kidney, and intrarenal reflux may finally leads to the pyelonephritis. In hematogenous route, the common agent like Staph aureus or even E. coli comes through the blood supply, and as a result of bacteremia, they cause infection. In the bacterial adhesions in the ascending urinary tract infection, first the contamination of periurethral area with uropathogenic E. coli. In bladder, type 1 fimbriated E. coli selected at high colony forming unit and low oxygen level. Then they ascend into the ureter, and here also the fimbria bind to the renal tubular epithelium. Finally, in the kidney, the hemolysis produced by E. coli damages the epithelium, and in the final step, cytokinin induction may lead to bacteremia. Pathogen in uncomplicated UTI are the E. coli as a most common cause, followed by Staphylococcus saprophyticus, Klebsiella, and Enterococcus faecalis. And in complicated UTI, E. coli still is the most common cause, followed by Klebsiella, Pseudomonas, Proteus, Enterobacteriaceae, Staph epidermidis, and so on. Gram-positive organism also may cause UTI, in which the most frequent are the Staphylococcus saprophyticus, Enterococcus, Streptococcus, and Staph epidermidis. In rare causes, there are Corynebacterium, Acinetobacter, or Aerococcus. These infections are easily overlooked because of limited culture-based assay utilized in hospital microbiology lab. In the early event of pathogenic E. coli pathogenesis, there are few steps in which the colonization of periurethral and vaginal tissue as well as the urethra, followed by ascending infection in the bladder lumen and within the urine, adherence of surface urothelium and interaction with the bladder epithelial cell defense mechanism finally lead to biofilm elaboration in case of high virulence, and followed by invasion and replication by forming bladder intracellular bacterial communities, and formation of quiescent intracellular reservoir can stay in dormant in underlying urothelium and leads to the recurrent infections. In some cases, the renal colonization and host tissue damage may lead to the high septicemia. Bacterial adhesions are the molecules that allow uropathogenic E. coli to attach to the urinary tract tissue of host. It is classified as fimbrial and afimbrial. Bacteria with high adhesive capacity are shown to cause more severe infections. In type 1 Papillary, these are the known as mannose-sensitive hemagglutination. These Papillary mediate hemagglutination of guinea pig erythrocytes. The reaction is inhibited by adding mannose, so is the name. And they are commonly expressed in pathogenic and non-pathogenic strain of E. coli. They have established role as a virulence factor in UTI. P. mannose is a mannose-resistant Papillary. P is referred for pyelonephritis, and they confer trophism to the kidney. They mediate hemagglutination of human erythrocyte that is not altered by mannose. P. papilli in acute pyelonephritis are important mainly in non-refluxing or minimally refluxing children. Minimal correlation is seen between P. pilated E. coli strain and recurrent pyelonephritis with gross reflux in girls. Another fimbrial papilli is S. papilli, which bind to sialic acid residue via S-fast adhesion and associated with bladder and kidney infection. Other adhesions are afimbrial adhesions. These are responsible for maintaining this connection. One is TOS-A adhesions, which expressed during UTI in 30% of urinary tract sample, and the iron-regulated adhesions, which mediated adherence to bladder epithelial cells. Catch bonds are a finger trap-like mechanism mediated by shear altered interaction between fimbriae, H. papilli, and mannose binding domains. They enhance force-induced tightening of the mannose binding pockets. Uropathogenic E. coli adhesions have evolved to meet the physical dynamics of the urinary tract. The affinity of E. coli expressing specific fimbria H allele for erythrocyte enhances by shear stress. Similar shear stress enhancing binding now appears widespread in biology and include E. coli with P. fimbriae And they promote uropathogenic E. coli retention in the urethra and bladder during voiding and in the ureter against peristalsis. In the absence of shear, reduced Fimbria affinity would facilitate diffusion and thereby promote ascending infection. Epithelial receptivity is also important. There is increased epithelial receptivity for E. coli on the introital and urethral mucosa. In women with recurrent UTI, there is high vaginal receptivity was associated with high buccal cell receptivity. Thus, the women are more susceptible to UTI and suggest a genotypic trait. Along with this, the lower estrogen level, as in case of postmenopausal women, associated with the risk of recurrent UTI, which can be prophylactically treated by local application of estrogen. HLA-A3 may be associated with increased risk of recurrent UTI. Phase variation in the bacterial pili is seen in vivo, where environmental growth factor condition can produce rapid changes in pilus expression. Cells switch back and forth between pilated and non-pilated phases. Some bacteria grown in both medium expresses pili, where the same strain grown in the same medium in a solid state will cease production of pili. This is known as phase variation. It can occur in vivo also, where the type 1 pili are advantageous to the bacteria for adhering to the adhering and colonization the bacterial bladder mucosa, and at the same time these are disadvantageous for the bacteria because the pili enhances phagocytosis and killing by neutrophils. Strain isolated from the different site in the urothelial tract shows variation in the state of pilation. This picture depicts the biofilm formation, which initially is reversible, followed by irreversible attachment to the surface through the platonics, and for finally formation of external matrix, then followed by biofilm acquires a three-dimensional structure, and finally the biofilm detachment and spread of infection. Bladder cells have luminal surface of bladder is lined by umbrella cells. Apical surface of umbrella cells has membrane protein known as uroplakins. Uroplakin 1A and uroplakin 1B can specifically bind uropathogenic E. coli expressing type 1 pili. Fimbria H-mediated binding to the bladder epithelium is the initial step in the intricate cascade of event leading to UTI. Once intracellular uropathogenic organism rapidly grow and divide leads to early intracellular bacterial communities. Between 6 to 8 hours of inoculation, early IVCs drops in bacterial growth and phenotypically switch to the biofilm-like communities. Bacteria on the edge of IVC detach and motile and escape known as late IVCs. In this picture, the type 1 pili is getting attached to the uroplakins and leads to invasion and apoptosis. And after binding to the alpha-3 beta-1 integrins, they mediate invasion and binding. This binding followed by intracellular bacteria communities, formation and pod. Exfoliation of superficial urothelium expresses the underlying transition cell, and which leads to dormancy of bacteria and recurrent urinary tract infection. The natural defense mechanism of urinary tract are seen in periurethral tissue and vagina like lactobacilli, coagulase negative staphylococci, and normal flora forms a barrier with the uropathogens. Uromedullin is a TAM-Halls protein which all secreted by kidney, and the TAM-Halls protein saturates all the mannose binding site of type 1 pili, thus by potentially blocking bacterial binding to the uroplakin receptor to the urothelium. In the urinary tract, urine acidic pH of urine, high urinary osmolality, urinary inhibitor, or competitive mechanism, mechanical flushing of urine is as known as a defense mechanism, whereas mucosal immunity in form of immunoglobulin A, mucopolysaccharide, or in man the prostatic secretion are also protective for urinary tract infection. Urinary bladder defense mechanism of exfoliation or bladder flushing, and innate immunity in form of toll-like receptor pathogenic recognition also plays an important role in prevention. Alteration in host defense mechanism like comorbidity or vaginal alteration in vaginal mucosa pH or may lead to the urinary tract infection and septicemia. Catheter associated UTI is the most common cause of nosocomial infection, and it's saying 3% of all patients with catheter with bacteremia. Incidence of sterile urine conversion to bacteria occurs at a rate of 3 to 10% per day. In the pathogenesis, insertion of the urinary catheter leads to biofilm formation, and microbe attaches and finally detaches from the local from the biofilm and leads to symptomatic infection. Alteration in host mechanism leads to recurrent UTI, in which the obstruction causes increased susceptibility to UTI. Stasis compromises bladder renal defense mechanism. It also increases bacterial growth and their ability to adhere urothelium. And obstruction clearly increases severity of infection, but it need not to be predisposing factor in as in man with large residual urine may remain uninfected for the years. VUR in children, especially high-grade VUR and UTI, cause progressive renal damage, and lesser degree of reflux may improve or completely spontaneously with recurrent with after treatment of UTI. In adult, presence of UTI has not appeared to be decreased renal function. Underlying disease like diabetes, sickle cell disease, analgesic abuse, sulfonamide nephropathy leads to renal scarring in patient with chronic interstitial nephritis, almost all of which produce renal papillary damage. Woman with diabetes has increased risk of UTI, but the man with diabetes has no substantially increase, and other contributing factor may also play a role like poor glycemic control and impaired immunity. And the relationship between UTI and glycosuria has no evidence to support this. Upper urinary tract involvement is seen in 80% of patients, and atypical infection like yeast are more common in diabetic patients. Renal papillary necrosis is a spectrum of disease from acute fulminant to the chronic stage. Some patients may chronically pass necrotic tissue in their urine. Retained necrotic papilla may calcify to form nidus for chronic infection. Analgesic abuse associated with increased incidence of urothelial tumor than UTI, and the ureteral obstruction by sloughed papilla with concomitant UTI is a neurological emergency. Conditions with other conditions with retroperitoneal renal papillary necrosis are pyelonephritic or maybe hypoxic. In pyelonephritic, these are the immunosuppressive and conditions like diabetes mellitus, transplant, analgesic abuse. In hypoxic condition, there are medical renal disease like jaundice, cryoglobulinuria, necrotizing angiitis, and hypotensive shock. HIV increases the risk of UTI by 5-fold, and higher rates of Acinetobacter and Salmonella infection. Patient with AIDS have higher risk of atypical infection, especially in a stage of CD4 count less than 200. Fungal infection like Cryptococcus, Histoplasma aspergillus candida are more common, and bacteria, mycobacteria is common, whereas viral infection, adenovirus are common. CD4 count less than 200 are generally associated with pneumocystis pneumonia prophylaxis with trimethoprim sulfone methoxazole. It decreases the UTI infection. Other conditions like renal transplant also increase the infection, and they are higher incidence of antibiotic resistance and recurrent UTI. Recurrent UTI in renal transplant patient associated with female gender, elderly male, and indwelling catheter and cadaveric donor transplant. Menopause pregnancy is also associated with the recurrent infection, and in the spinal cord injury with high bladder pressure with bacteria, there is no group compare in severity and morbidity such as spinal cord injury, because they require catheterization. They have associated with ureteral dilatation, hydronephrosis, reflux, and renal calculi. Behavioral factor like sexual intercourse, voluntary deferral of micturition, and new sex partner also increase risk. In the recent advances, there are serum biomarker for UTI in women with recurrent UTI, IgG, IgM, and IgA has been associated, especially in case of complete antibiotic therapy patient. And a study in mice, the level of serum hormone granulocyte colony stimulating factor and interleukin 5 was high in mice with reinfection. A cytokine macrophage colony stimulating factor was elevated in recurrent UTI in female, and increased serum PSA level has potentially protective role in a recurrent UTI, where in which the man with PSA level of higher than 4 nanogram per ml at UTI onset were less likely to have recurrent UTI than those with PSA less than 4. Serum vitamin D is in premenopausal women also important, as in recurrent UTI it was seen that lower level of serum vitamin D. In urinary biomarker, serial urinary nerve growth factor level in women with UTI recurrence was significantly low, and an NGAL known as neutrophil gelatinase associated lipocalin iron transformating protein in patient UTI recurrent NGAL level were significantly decreased. This might result from reduced toll-like receptor expression and reflect defective innate immunity. In cross-sectional survey, interleukin 8 was significantly higher in patients with bacteriuria and with higher serum neutrophil level predictive of recurrent UTI infection. As a take-home message, that the most UTI are caused by bacteria, usually originating from bowel and skin flora. Bacterial virulence factor, including adhesins, play a role in determining which bacteria invade the extent of infection. Increased epithelial cell receptivity predisposes patient to the recurrent UTI and is a genotypic trait. Obstruction to the urinary flow and low immunity state is a key factor in increasing host susceptibility to UTI. The serum and urinary biomarker not only have potential predictive value, but also might involve the systemic or regional pathomechanism in patient with recurrent UTIs. Thank you.
Stop sharing. So,
thank you, Rajeev. And if the residents or faculty have any question, we will take them. In the meantime, Mr. Nimesh, do we have faculty from outside? So let me know.
Dr. Arif is there, sir.
Dr. Arif is there. Dr. Arif, if you can open your video. So in the meantime, I will just briefly summarize. See, urinary tract infection is a very common problem. And often we do not give that much of importance to it, which it is due to. Because almost 150 million people worldwide suffer every year from urinary tract infection, which results in a huge, not only economic, financial burden to the society, but even there is a suffering of these patients, which results in loss of working hours, their loss of their quality of life, and everything. When we talk about recurrent urinary tract infection, I think he missed about the definition of recurrent urinary tract infection. That's very important. You might be asked about what is the definition. So if there are 3 uncomplicated lower urinary tract infections every year, or 2 every 6 months, or 2 cases of upper urinary tract infection like pyelonephritis every year, that is recurrent urinary tract infection, right? So this recurrence could be due to either relapse or due to the persistence of a bacteria even after giving antimicrobial therapy. So basic, if we go into the pathogenesis of recurrent urinary tract infection, so we can say it is related to bacteria itself, and the other is host-related. So bacteria-related recurrent urinary tract infections, the commonest pathogenesis is there are many bacteria which will form intracellular community in the epithelial cells, which results in persistence of these organisms, and they cause recurrence. Secondly, there are certain bacteria which are more virulent, as I said about the type 1 pili and P. fimbriae, which are bacteria which get adhered to the uroepithelial surface and results in persistence of this infection or recurrence of this infection. Similarly, the host-related could be if there is a problem with the immunity, if the patient has immunodeficiency, which could be due to either immunosuppression, could be due to steroids, could be due to chemotherapy, and many other causes. And secondly, there are behavioral factors. That behavioral factors will include like postmenopausal women, patients who have estrogen deficiency, patients, even multiple sex partners can result in recurrent urinary tract infections. And patients who use often spermicidal jelly can cause recurrent urinary tract infections. So there are many behavioral problems, less fluid intake, and many other things. So when we talk about some advances in the management of recurrent urinary tract infection particularly, then in the imaging study, there are something like there's an MRI which tells you about the epithelium and differentiates between scar and inflammation. Even Doppler ultrasound study can give a microvascular imaging of the uroepithelium. Similarly, now we have a concept of urinary microbiome, which can be detected by next generation sequencing of urine culture. And that it is one of the important upcoming pathogenesis of a urinary tract infection, which tells there is a dysbiotic urinary microbiome, or even the dysbiotic gut microbiome will result in more chances of urinary tract infection. So these are something which are upcoming. And then amongst prevention, there are 4 measures. One is the behavioral modification, then the avoidance of the risk factors, which can result in urinary tract infection. Then there are certain non-microbial measures, like there was a study on cranberry juice that it can avoid recurrence of urinary tract infection, but latest studies have shown that probably it doesn't make much of a difference. Then there are probiotics, then estrogen therapy, particularly in postmenopausal women. Oral therapy usually doesn't help, but local application of estrogen, which decreases the vaginal pH, would help many of these postmenopausal women who have recurrent urinary tract infection. And then we have already in market vaccines available. So there are vaccines for recurrent urinary tract infection, which come as either sublingual or oral vaccine also, which comes by OM89. There are multiple E. coli strains which are present in this vaccine. They will produce a kind of an active immunity in these patients. And similarly, there are vaginal vaccine also available, the Eurovac. So all these are the upcoming recent advances, and it's a very interesting topic. So I would ask any of the residents if you have any query, and Nachiket, if you want to say something. Okay, Neeraj, can you come in and ask? And Dr. Arif, if is there. Neeraj, are you there? I would ask Dr. Neeraj to please unmute himself. And if anybody else has anything to say, residents, do you have anything to say regarding UTI? I think Neeraj probably is not responding. So, Dr. Nachi, you want to say anything? Come, you come this side. Yeah.
I think that first of all, you didn't present well. You cannot come at this forum and say slides verbatim. Itni bari baat ho gayi. And dusra, your presentation was, as Sir Renal did half of your presentation, about recurrent UTI. Because the most important, we usually go into the factors which are responsible, but then you didn't touch upon anything about how you can prevent a UTI. Because clinically, I think that is the most important thing for females. What you do, Sir has talked about, probiotics, he's told about the estrogens and everything. You should have touched that inside your presentation. There wasn't a single slide about that. Then these patients, how do you give antibiotics also is important. When do you give start therapy, stop therapy, for how long a duration do you want to give? What type of antibiotic you want to give? That also was not, brought up inside your presentation. UTI vaccine, Sir has already told about the role of estrogens. You did not tell that inside, because half of your presentation was the prevention and the recurrent UTI. Pathogenesis and recurrent UTI. So you have to, this is the most important clinically. Patient is not concerned about the PPI or the fimbriana. He wants to know how to get over this problem of rigor. Then you haven't told about the importance of water. Sir, I remember in COVID, there was a UTI seminar, and there actually now has been a randomized control trial in which a good randomized control trial has shown that increasing water intake can prevent recurrent UTI. And this was as early as 2018. So this was a landmark trial, which again you should have, covered inside this. So these are the important things which mean, clinically for the patient, and not Renal. So you didn't talk about that. And then one of the drugs, I think that methamine maleate, you didn't touch about that. That is actually one of the drugs which has been found to prevent recurrent UTI. Unfortunately, we don't have it in our country. What I'm saying is that you've done a shoddy job of your presentation, right? And methamine maleate, sir, is available inside Europe. It is available in USA. So it gets converted into formaldehyde, and that formaldehyde is bactericidal. And that is the few drug that if companies bring this drug, then it will bring them big money also, and it will revolutionize the treatment of recurrent UTI. I'm more blunt than sir, but I think that you didn't do a good job today, because this goes everywhere. And then you are representing the department. So I think that you should pull up your socks. And the important drugs which are in the pipeline, he told about UTI vaccines, which are available in the market. Unfortunately, if you don't know about them, you'll not use them in the OPD. So, and they're very cheap. In a 250-300 rupees ka ek capsule aata hai. Matlab 1 mahine ka aata hai. Oral capsule is available. So I think that next time you should continue your seminar, and there should be another part about recurrent UTI, how to prevent recurrent UTI, what is the role of even vaginal washes increases the incidence of UTI, what is the role of protective flora, how do they protect inside the UTI. Females are coming because they are over using vaginal washes also, and wo sab khatam kar dete hain normal flora, which leads to recurrent UTI. What is the problem now? Because these V washes weren't available 10 years back, but there has been a sudden surge of these UTIs due to that. So what I request, sir, is that maybe next time he should cover, because that is the most important thing about the topic.
Yeah. I take your point, Nachiket. There was slight confusion because the topic probably he was given pathogenesis of UTI recurrent, so he probably didn't take this prevention and measure management. But you could have given one or two slides because this is a very important topic. As you said about those preventive measures, particularly in women. In women, why the women are more affected by UTI. Anybody can say? Shorter urethra, yes. Short urethra and nearness to the anus, right? It is very near to the anus. So usually all these bacteria come from where? Bowel only. So this bowel fecal bacteria will colonize the perineum, vagina, and periurethral region.
Sir, can I come?
Yes, please.
Yeah, आपने इतनी important चीज बोली है. There is also studies which have shown that females who clean their perineum from the anus to the vagina, studies है. And from those who can clean from forward to backward.
Yeah.
They have studied. People have studied the instance of recurrent UTI inside those females also.
So these are some of the measures which can prevent UTI. And when we talk about prevention, I had a webinar in Vesicoureteral Foundation on recurrent UTI. I was probably panelist or moderator, probably. Dr. Dalela was also there. And we very extensively discussed about how to prevent recurrent urinary tract infection, which is becoming a very, very common problem in women. And as he said about the vaginal washes and all that, which can result, I just researched on how the undergarments ladies wear, or even men, but it is more relevant to ladies because these undergarments probably could be a source of recurrent infection. There was a study which showed that undergarments which are worn almost 24 hours, and some of them are made of material which are non-breathing kind of material, and they are which produces a hot and humid climate there. which helps in the growth of bacterial organisms. And it has been seen, they have studied that even properly washed undergarments, they have fecal bacteria in the undergarments. Even if you wash it 2 or 3 times, still it remains. And we know how probably in conditions like our country, who are not educated people, the hygiene is not properly taken care of, how bad it could be.
Sir,
And this is, yes, please. Yeah.
As a matter of fact, fecal contamination, अपन लोग तो water use करते हैं. Inside Western countries, they don't use water. They just use those tissue.
Yeah.
तो जो fecal marks रह जाते हैं undergarments पे, उनको वो लोग skid marks को.
Okay.
जैसे टायर की skidding होती है ना, तो skid marks रह जाते हैं पीछे.
Right.
So that is, they say, is also responsible many times for the UTI.
Exactly. So those who are used to ablution by tissue paper, so maybe the fecal bacteria are remaining there and was causing more of a colonization there, chance of infection. Even the use of tampons and these undergarments, what they do, they produce a thing called chaffing. So what is chaffing? Chaffing is these undergarments can produce abrasions of the skin area in the perineum and the vulva, and that abrasion is more prone to a colonization of bacteria, and that results in recurrent urinary tract infection. So some of these are very untouched areas, and I think some of us should take up this probably study on what could be the causes for recurrent urinary tract infection in women, and this could be path-breaking, I think. So thank you, everybody. Thanks all the residents, and thanks all the faculty members. If any of the faculty who has joined us has anything to say, I can't see anything on the chat box. So I would request Dr. Ajay to please come and wind up the session. So I don't see anything on chat box, and I don't see anybody has any query. So Dr. Ajay, please.
First of all, thank Dr. Rajeev for the nice presentation and covering almost important points. And also, I would like to thank our guide and mentor, Shivam sir, for enlightening us, imparting our knowledge about UTI in urgent scenario and recent advancement, and what should we do for society in future. Thanks, sir.
Thank you. Thank you, everybody. We'll wind up the session. Have a good day.